The talk I am going to give you came from the American College of Cardiology meetings, the most recent one, where I was asked to discuss the new guidelines for prevention of coronary disease in a controversial session in which the people who had written the guidelines and I took different points of view. The new prevention guidelines, the title of the session actually was called A Step Sideways or A Step Backwards, and you will see that I think that perhaps sideways is the best that we can give it. Let's first begin by talking about very briefly about what the guidelines say, because I imagine many of you are familiar with that, then what the limitations of the new guidelines are, and how I feel we can integrate these new guidelines into our practice of cardiology. The new guidelines have major differences from the former guidelines that we were given. First, they deal only with statin therapy. And the reason for that was that the guideline writers felt that they should only use randomized clinical trial data for any recommendations that they made. And so they focused solely on statins. They established 4 groups of patients who might be treated: those with coronary disease and stroke, diabetes, people who had an LDL cholesterol greater than 190, and the asymptomatic population. It was this last population that really generated the controversy. In addition, they eliminated all the LDL targets that we had been given, essentially said we don't need to have an LDL target, we'll just go by the dose of statin that we give. And they added a new risk calculator to replace the previous one for asymptomatic patients. In terms of the approach to asymptomatic patients, they recommended the Mediterranean diet, 30 to 40 minutes of exercise 3 or 4 times a week. They said that after you recommend that for your patients, calculate the risk of a person every 5 years based on having demographic information and lipid profile. And then use a statin if the 10-year risk by this new calculator is greater than 7.5% in people who are over the age of 40. Decide the dose of the statin that you give by the level of risk that you get from your calculator, and do not then subsequently use an LDL target, just stick with that dose. And they, regarding family history, C-reactive protein, calcium scan, and the ankle brachial index, they said none merited inclusion in the guidelines. The reaction to the guidelines was really fundamental, and it was also widespread across the world. From the Middle West of the United States came the comment, it turns back the clock on cardiovascular disease prevention. From the South, it is a massive paradigm shift that dramatically changes the approach to disease. From the East Coast of the United States, the guidelines will revert back once we get a positive study showing that adding another agent to a statin reduces risk. The Spanish Cardiac Society said we're not going to use the guidelines. Now, what caused this firestorm of reaction? There are 3 basic criticisms of the new guidelines. First is that they ignore our knowledge of atherogenesis. Second is that they eliminate the target LDL. That process makes no clinical sense for practicing physicians. And third, that the new risk factor calculator is seriously flawed. Let's look at each one of those limitations in turn. Let's look at the pathogenesis of atherosclerosis. It's a systemic disease. There are some down there in the femoral artery, but today we're going to focus on the coronaries. Here's a cross-section of the coronary, endothelial cells in the background. Cholesterol moves freely across the blood vessel wall, in by LDL, out as a part of HDL lipoprotein. But when there is an excess of LDL, in the blood. Some of the cholesterol gets trapped in the extracellular matrix, and when it does, it gets oxidized, turning yellow there. Oxidized LDL stimulates the endothelial cells to express adhesion molecules, those green things, and that pulls white cells, particularly monocytes, directly into the blood vessel wall through the gap junctions in the endothelium, where that monocyte now becomes a tissue macrophage and begins to gobble up all that oxidized LDL, becoming an active macrophage which expresses growth factors that create a fibrous cap over the noxious stimulus in the coronary artery. But that macrophage also expresses a second compound, which is a protease that dissolves fibrous tissue, and it dissolves and dissolves and dissolves through the fibrous cap until that cap becomes so thin at one point in the atheroma that it ruptures. And when it ruptures, a blood clot forms on the surface. If it's partially occlusive, that's unstable angina. If it is completely occlusive, that is an acute myocardial infarction. Now, why is the pathogenesis of atherosclerosis so important? The reason that it is important is that we know when atherosclerosis begins. Look at this fascinating study from the Cleveland Clinic by the by intravascular ultrasound. Steve Nissen was the senior author. And on the left side, we see that there is this study was conducted in 262 transplanted hearts, intravascular ultrasound of the donor heart, and using a 5 millimeter threshold for the presence or absence of atherosclerosis. We'll look first at the top left. You see a 19-year-old man who has the beginning of an atheroma there at about 4 o'clock. That is an atheroma over 0.5 millimeters. And below is the heart of a 33-year-old woman. If you were told, if you were a transplant recipient, that you were getting the heart of a 33-year-old woman, you would say, boy, was I lucky. Not so fast, McGillicuddy. Look at these coronary arteries of this 33-year-old woman. There is a very significant atheroma in her circumflex coronary artery, and on the right, another atheroma in her left anterior descending. Now, these investigators then stratified the presence of atheroma according to age in these donor hearts, and you can see that, for instance, at in 30 to 39-year-olds here, there's about a 60% rate of atherosclerosis present. True, it's probably in many cases small atheroma, but nonetheless, what we can say is that atheroma have begun to develop in much younger than we see the clinical manifestations. And that is borne out by studies from, autopsy studies from the Vietnam War. As you see below, 45% of 22-year-olds who died in action had atheroma in their coronary arteries, and calcium scanning more recently shows that 40 to 60% of people have calcium in their coronary arteries by age 45. So what can we draw from this data? Coronary artery disease becomes manifest in middle age, but it actually begins in youth. Now that's important because we can identify high risk in people when they are young. Here is a fascinating study from Bogalusa, Louisiana. It is a study in young school-age kids who had their risk factors, the typical risk factors, measured while they were in school, and then a small segment of those young people died in their early 20s. And the investigators went back and looked at the number of risk factors they had when they were in school, and then made measurements of the amount of atherosclerosis in their coronary arteries. What you see is on the x-axis that if there was more than 2 risk factors, those classic risk factors with which we are familiar, there was a vastly greater amount of atherosclerosis in those autopsied young people than, for instance, those who had no risk factors. That's about an 8-fold increase in plaque in the aorta. And the reason that that is important is that people who have risk factors in youth, those risk factors, because this is a 30-year study now, have been found to track into middle and older age. In other words, what we see in youth is what we end up with as older adults when we finally develop the clinical manifestations of coronary disease. And that's important because, as Bob Roberts showed us earlier, this particular study of the PCSK9 mutation, which occurs spontaneously in about 3% of the population. If you happen to have the PCSK9 mutation, which only lowers LDL by about 20%, you have about a 50 or 60% reduction in atherosclerosis. What that says is that a lifetime of lower LDL profoundly affects the frequency of coronary disease development. And so, the conclusion that I would draw is that since atherosclerosis begins years before symptoms, the guidelines should have promoted earlier management. But in fact, they gave us no guidance whatsoever in people who were less than 40. The guidelines fundamentally say start by doing the calculation of risk after age 40. Now, the second flaw, the first is we would have liked to have seen some more aggressive approach to management of risk earlier in the course of disease. The second flaw is that I believe we do in fact need a target because of these data. These are pooled data from angiography on the left, all the studies of coronary angiography, and the amount of change in stenosis over time, over 5 years of time. These are all 5-year angiographic studies as a function of the level of LDL lower, on treatment LDL. And what you see is there's a relatively linear progression or regression of disease as a function of LDL in people who have coronary stenosis. And on the right, in primary prevention, that is people not known to have coronary disease. And now we look, instead of disease progression, at heart events, coronary events. Did they or did they not have a cardiac event? There's a lot less data in the trials of asymptomatic people, but the data looks as if it falls linearly as a function of the level of LDL. And if we extrapolate to 0, that would be on the left side in coronary disease. Is there 0 coronary disease progression? It looks like that would intersect at around 67 milligrams per deciliter. And in people on primary prevention, that intersects at 57 milligrams per deciliter. In other words, if that data were true, we could, and of course it's an extrapolation, we could say, if you get your LDL down to 57, you will not have a coronary event. Of course, that's an overstatement, but it is an insight into the need for a target for us to go to. And it looks like that target would be in the range of 50 to 70. Now, LDL levels in animals, the entire animal kingdom, in the rhinoceros, the wild pig, various kangaroos, all kinds of animals have now been measured by, even in wild animals like lions and tigers, have been measured by intrepid epidemiologists who've gone out and drawn blood, and they have found that the entire animal kingdom falls essentially in the range of less than 70 milligrams for LDL cholesterol. As do we. When we are born, we're born with an LDL cholesterol of about 40, and then we go to, we break through 70 at about age 12, and just continue on up. In the United States, our average LDL right now, LDL cholesterol, is around 120. So LDL levels in animals, humans. There are human populations, isolated human populations, so-called hunter-gatherer societies living the way we did perhaps a million years ago. And they also fall into the range of 70 milligrams per deciliter. And finally, these clinical trials all suggest or infer that the normal LDL is probably in the range of perhaps 50 to 70. So the question then is, if we treated our asymptomatic patients to a level of LDL less than 70 or around 70, would it be safe? And we have data from the so-called Jupiter trial in a subset analysis in which, as you see on the right, some of the patients actually got to LDLs less than 50 on 20 milligrams of rosuvastatin. And that small segment of the population, compared to the entire treated population, had a further reduction in cardiac events of about 20% with no increase in toxicity. So that the linearity of decreasing risk does appear probably to go beyond 70 milligrams per deciliter down into the range of 50 or so. And the point is that that treatment appeared in this clinical trial over a 2-year period to be safe. So we need an LDL target because coronary disease progression and clinical events, and geographic progression and clinical events, are markedly reduced as LDL falls to and below 70 milligrams, whether or not a person has symptoms. And that also is the second great flaw in the new guidelines. The third flaw, the risk calculator turns out not to be credible. It overestimates risk by about 75 to 150% when compared to 3 contemporary databases that has now been compared, most recently just in the last month or so by Paul Ridker in a recent publication. And it ignores people less than 40 years of age. You can't see the ages here on this. I'm going to, the top example is a 60-year-old man with no risk factors, a total cholesterol of 150, HDL of 45, blood pressure of 125, seems to be at relatively low risk, but his 10-year risk is calculated as 7.5%, and he qualifies for statin therapy. And it turns out, using this new risk calculator, that everyone over 65, essentially everyone, requires a statin. On the other side, here is a 40-year-old man whose father died of a myocardial infarction at 45. He has a total cholesterol of 310, an LDL of 180, HDL of 50, triglyceride of 400. His 10-year risk leads to the conclusion that he does not need statin therapy, even at the first level where you can calculate it, which is at age 40. Now, that 25-year-old man, I would submit, if he cannot do anything with diet, needs to be on therapy well before he has his myocardial infarction at age 39. So the point is that what this calculator does is it overestimates risk in older people and it underestimates risk in younger people. The 3 fundamental flaws of the new guidelines. It ignores critical knowledge by focusing only on randomized clinical trials. The data that atherosclerosis begins in use and increased risk is identifiable years before symptoms. It eliminates the treatment target, so now you have, takes out a fundamental process of medicine, which is you treat and then reassess. With these new guidelines, you treat and you stop because you have no endpoint. Lower, in fact, is better. and so we should be driving for a lower endpoint, and we're left with no way to assess effectiveness. And the risk calculator is seriously flawed because it overestimates risk in older and underestimates in younger people. And that then leads us to the question, so the new guidelines are flawed, what should we do? And here's what I believe is the appropriate approach for us, and it is the approach that we follow at Cedars-Sinai, and I think probably much of the United States. You get a lipid panel in young people. We recommend everybody over 20 years of age. That is consistent with Lipid Society guidelines. We essentially ignore the 10-year risk calculator, this new risk calculator, because of its flaws. And we assess risks as we always did, which is essentially using the Framingham risk factors, but using our clinical judgment as to that patient's risk. We also think more of a person's lifetime risk. In other words, we are willing to treat people under 40 if they have high risk by our assessment. Rather than focusing on a 10-year risk of an event, when we know that half the people who present with coronary disease first present with a heart attack or sudden death. So we have to start managing people who are asymptomatic but have factors that suggest high risk. We use a calcium scan for people who are over 40. We don't use it so much under 40 because it can give you a false negative. But over 40, we use the calcium scan for people who are borderline, and we want to have more evidence that they deserve to be on therapy if they cannot control their risk by lifestyle alone. So we do use calcium. The management, we begin, in terms of management itself, we feel we should begin prevention earlier. We explain a prudent diet to all our patients. We set 70 milligrams as a goal for all our patients, symptomatic and asymptomatic, and we accept the fact that with current drug therapy, in many cases we won't get to 70, but that doesn't mean it's not our goal. We arbitrarily have set our lower limit as about 40 to 50. If it gets below that, we back off on statin dose. We use generic statins quite a bit because they are much less expensive, and we think that you can use those in asymptomatic people with elevated LDL, provided that the cost and toxicity is not a problem. And finally, we do use secondary drugs like ezetimibe in people who are at high risk but not near the LDL target. Now, I have to say that although I am critical of the guidelines as written, I do believe that independent of the flaws in the guidelines, we are moving in the right direction. Coronary disease mortality currently exceeds cancer by about 10%. In the United States, by our best projections, it is projected to fall between 24 and 30% within the next 6 years, by 2020. In Canada, coronary disease is no longer the #1 cause of death, and I believe that will occur in the United States within this decade. So we can congratulate ourselves as a society of cardiologists that we are moving to eliminate the scourge of the 20th century. Now, what about these guidelines then? Well, what I want to suggest is that we've got to get away from doing the same thing over and over again, trying to rely just on randomized clinical trials. Get outside the box. Stop running around in circles and come up with new concepts and new ideas. And if we pursue those with diligence and we keep after it, we are clearly on the way to seizing the prize. And if we do, I think that as we eliminate coronary disease as the #1 cause of death in the world, we will deserve a pat on the head. So thank you so much for having me here to speak to you.